All right, good afternoon, everyone. Thank you for joining us for the webinar, Rural HIV Care and Prevention. For your information, all participants' microphones are muted today. If you have any questions that you would like to be addressed after the presentation, please use the Q&A box that's located in the bottom of your screen in the Zoom menu. The chat box is also available if you have any comments or technical questions. My name is Savannah Holt. I'm the Sexual and Reproductive Health Program Coordinator with the Saskatchewan Prevention Institute. The Prevention Institute is a provincial nonprofit organization that's located in Saskatchewan on Treaty 6 territory and the homeland of the Métis Nation. Our organizational focus is to reduce disabling conditions in children using primary prevention methods. We raise awareness by providing training, information, and resources based on current best evidence. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We work in a variety of areas, including sexual and reproductive health, fetal alcohol spectrum disorder prevention, maternal and infant health, early childhood mental health, child injury prevention, child traffic safety, and parenting. One focus of the Sexual and Reproductive Health Program is to provide evidence-based information on sexual and reproductive health that is accessible to healthcare practitioners and allied health professionals. Saskatchewan has high rates of sexually transmitted and bloodborne infections, and in 2019, transmission rates of HIV were 2.4 times the national 2018 average. Some rural communities have much higher rates of transmission than the provincial average, and 78% of newly diagnosed females were of childbearing age. With early detection and consistent and effective care, interpersonal and vertical transmission can be reduced, and those who live with an HIV diagnosis can live long, healthy lives. It is now my pleasure to introduce our speakers for today. All three of our speakers today have very impressive biographies, which will be available in full on our website, but I'll give a little brief overview of everyone in the meantime. So Dr. Jolie Sasakamoose is Wellness Wheel's research director, responsible for leading the research team in supporting traditional ways of knowing alongside Western approaches to well-being. She's a proud Anishinaabe Ojibwe with membership in Michigan First Nation in Ontario, an active citizen of Atakakuk Cree Nation in Saskatchewan, and an associate professor in educational psychology and counseling at the University of Regina. She co-authored the Indigenous Cultural Responsiveness Theory and has an exceptional way of working in the middle ground between Western and Indigenous ways. Dr. Stuart Skinner is a clinical investigator currently working at 10 outreach clinics, serving 21 First Nation communities. During his 7 years developing the Know Your Status program, he has built strong relationships with Indigenous leaders, regional, provincial, and federal health authorities, agencies, and health ministers, and local clinicians. He has produced numerous conference presentations, publications, and abstracts on HIV in Indigenous communities and has received financial support for his research. He also works within these communities directly. Suzanne Nicolay is the clinical coordinator and nursing lead at Wellness Wheel. She works closely with communities that Wellness Wheel works with and is primarily involved with Touchwood Agency Tribal Council communities. Suzanne is a registered nurse with practice roots in medicine and chronic disease care. As an AIDS-certified registered nurse, much of her nursing career has involved HIV clinical care, and she has also specialized training in hepatitis C care and diabetes management. Suzanne is a current board chair for CAIDI, the Canadian AIDS Treatment Information Exchange. And now for today's presentation, Rural HIV Care and Prevention.
Thanks, Savannah. So I'll just start sharing my screen here. Okay, can everybody see that? Stu and Jolie, can you see that, the slides? Okay, perfect. Okay, so I'm Suzanne Nicolay, and it's my honor and pleasure to offer a land acknowledgement. So I am of settler heritage. My family has been in Saskatchewan exclusively for the last 100 and some odd years. My heritage is largely English, Austrian, and German. So I do identify as a white settler. I'm a guest on these lands, and I just would like to acknowledge that I am living, working, and playing in Treaty 4 territory, which includes the Cree, Anishinaabe, Dakota, Lakota, and Nakota, and is also the homeland to the Métis. I offer this land acknowledgement as part of my work regarding truth and reconciliation, and I do acknowledge that the ancestors share this land with us, and I'm very privileged to be living and working in this territory with the communities that I work with. So these are the objectives for today. So to give you a brief overview of Wellness Wheel, if you don't already know what and who we are, to talk a little bit about the current state of HIV in rural and remote Saskatchewan, including on reserve communities, talking about challenges, risks, and resources, including the inequalities in accessing care in rural and remote communities. Of course, coming from that strength-based perspective, talking a little bit about pregnancy and HIV in a rural setting, including care and transmission prevention, and then lastly, providing recommendations and promising practices in terms of improving rural and indigenous health and prevention strategies in equitable access to care related to HIV. I'm going to turn it over now to Dr. Skinner.
Thanks, Suzanne, and thank you all for coming, and thanks to the Prevention Institute for asking us to speak and kind of hopefully share some of our experiences. I've been doing this for 10 years now, and it's really nice to talk about something that's not COVID, because everything has just all been COVID, but this is really my passion in working in and with communities and Indigenous people and the patients I serve. I would note that COVID has also certainly exposed the deficiencies, the gaps, and the needs of our health system in a whole variety of areas. And as we work our way through COVID, there's opportunity for change in terms of how the system, province, people, communities as a whole approach health. And it's very humbling with COVID that despite what we think is great Western medicine, the only thing we have to offer are masks, gloves, and public health measures. And it really exposes the way our current clinical health system just can't do anything for, in this case, COVID, but a whole variety of other areas. And to me, it's a recognition for the importance of partnership. We think of wellness more than just HIV viral load or a hemoglobin A1C, that you could be undetectable with HIV but be not well or struggling because of the gaps with mental, spiritual, and emotional health. And that's really what we are looking to do, or our whole approach has been. For me, this started 10 years ago now, as just kind of working and the recognition of what access to care really means and what care really is defined as. It's so much broader than a physician, because we are so limited in what we can offer, that for me, to be able to partner with community leaders, traditional health practices, and patients themselves, to be part of a team and a group that actually really looks to wrap around care for really kind of bringing health and wellness. And this started for me years ago because we live in a clinic-centric world. Everything relies on people coming to a physician or a hospital or a clinic, and that approach doesn't work. I think true health and wellness means going back out, going to where communities are, where patients are, and bringing it back to the that original model of at least Western medicine with the doctor in his black bag going out to people's houses. And I've realized over the years the incredible gaps in care, the unique challenges in rural areas and First Nations communities, or inner city communities for indigenous people, in terms of accessing, and it's equitable access to care. It's not just access to care, it needs to be equitable and strength-based. And the strongest people I've ever met are my patients, who have battled through so many challenges and are so strong. And over time, what we do is evolved from what started as HIV, then into other infections, but then into broader chronic disease perspective, but then bringing it into a wellness perspective, and really trying to work together with those local leaders and health providers and traditional wellness and health providers. And then as things evolved, I'm not a researcher. I'm primarily a clinician and will always think of myself as a clinician. Research is only a means in my mind to show evaluation that actually we can do things better, and the need to evaluate to kind of show that to our various levels of government leaders, and be able to fund a different way to look at things. And very lucky that Suzanne came to work with me and partner with me, and the work from the peers in TATC and Val Desjardins as things developed, and then working with Jolie as well from the indigenous perspective, who always kind of brings us back to the key principles of what we're trying to do and approaches that lens, which I really think is two-eyed seeing. So it's evolved, and now we've kind of partnered. Not only is it a partnership between Western medicine, traditional medicine, community clinic, but also research and health and providers. And so it's everyone building on our strengths, work with what we're strong at, and partner with others who are strong in other areas where we're not. So that's kind of the background of what we do. Next slide, Susan. This is, I feel like I've said what I'm about to say for the last 10 years. And I find this frustrating, that for 10 years in Saskatchewan, we've had the highest rates in Canada, and that hasn't changed. In 10 years, we're still the highest rate in Canada. We had a little bit of improvement in the early 2010s, but the rates are increasing, and COVID's only exposed this more, where the people struggling with mental health or addiction or access to care, and those services have been even reduced further, and we're certainly seeing a worsening of mental health and addiction, and more HIV outbreaks and rates. For years, we've said since 2016 that this wasn't an isolated problem in Saskatoon or Regina or Prince Albert. People are mobile and moving back and forth. And initially, we've always known this, and it highlighted the gaps, the areas, because the only place people could actually access care or get testing was in the major urban centers. And where you get diagnosed depends on where your home address is listed. And so it was concentrated in the major centers, but this has always been an epidemic throughout the province. And it's disproportionately affected Indigenous people for 10 years, and that hasn't changed. What's changed a bit, and I think you see this in the most recent numbers, is that there's been an improvement somewhat in access to testing in communities and in rural areas, and care in communities and rural areas. And so we've seen that shift into various communities throughout the province. You know, the former Prince Albert Parkland Health Region, Prairie North are high rates. We've seen outbreaks in Sunrise and in various communities, and especially in the rural communities, these are explosive outbreaks. You have, you know, injection drug use can be very efficient in transmitting HIV, and you can go from, you know, 1 to 20 people infected in a matter of days or weeks. Next slide. So that's this kind of says more or less the same thing that I've said before. And so if we have to match where care is given to where the people are, and that means providing a system or approach that is equitable and is available everywhere. And equitable, I think, is the key piece. People should have the opportunity, no matter where you live, to the same care, services, support that's available in any urban center. And certainly with technology, this is an opportunity where this can be achieved. And we really need to kind of look at doing things in a different way. Next slide. And these are just kind of similarly on the left is just the rate by health region in 2016. The right is kind of the 2019 data, which is the previous slide. It's the bottom line is this is throughout our province, and it's everywhere. But to treat HIV is more than a number or a test or a pill. It's treating that person for the underlying risk factors for HIV. HIV is a symptom of all the underlying limitations with access to care, racism, limited access to harm reduction services, limited partnerships and autonomy for, you know, First Nations health in the communities, and we have to think upstream. And as a physician, as a white physician, I'm not the answer. I can help get people on HIV treatment, but it's community that actually is going to bring wellness, and community needs to be supported with the resources to do that. And we need to listen to community. Next slide. Certainly, Saskatchewan is significantly overrepresented in compared to other provinces, other areas, based on, you know, sex, that women are much more frequently infected with HIV and affected by HIV. And it's not just HIV, especially for young indigenous women. We see the impacts of not just HIV, but other complications maybe related to substance use and racism and across the board. For example, you know, this is an HIV talk, but we looked at endocarditis just recently, which is an infection of the heart valves. And young indigenous women were more common than any other group to suffer from endocarditis, and with a 50% mortality at 5 years. So we need to look to find better ways to support this group. From an HIV perspective, the challenges specifically with pregnancy and access to care for pregnancy are significant as well. And again, equitable care that's supported and available locally in community. And next slide. I think that this is, yeah, so I'll pass this back to Suzanne, and thank you.
Okay, thanks, Stu. So just to build on what we've been talking about, I mean, certainly there have been high rates of HIV for a long time in the province, and the previous slides did certainly show, even since 2016, an ongoing increase, and certainly the burden has passed from sort of the bigger urban centers to smaller urban and rural remote settings. Despite that, there is some positive things happening. Certainly the release of the perinatal HIV prevention protocols were a very needed tool to support women delivering in their home communities, and helping providers to sort of streamline and, put into practice the best practices that are available in terms of diagnosing or managing women who have unknown status, but may have risks in terms of providing meds during that interpartum stage. So those are available on the provincial HIV website, and the link is there. So these are a really good resource, particularly for smaller facilities. The other really amazing thing that started almost 10 years ago now is the Saskatchewan Infant Formula Program. So this came into being as part of the HIV strategy that launched in sort of 2011 or so. And it was a provincial initiative to provide formula to all HIV positive women, regardless of whether they lived on or off reserve, regardless of urban, rural status, non-status, those kinds of things. So this program provides for a significant amount of formula, up to 48 weeks, I believe. I think 48 weeks, I could be wrong about that, but almost to the first birthday for the infants. And there is some flexibility in terms of the type of formula that's available. And again, I think what's really amazing about this is that it doesn't separate jurisdictions. So if a woman is living on reserve who requires this, there is no issue in terms of her accessing that. And it's basically, if people aren't aware, it's managed similar to a prescription refill program. And in my experience, typically this is set up in advance of a woman having her baby. And so those supports are put in place in a plan prior to delivery, which is also very helpful. So there's been some tremendous success regarding that. And you can see that on that little top diagram there on the right. I think it's important when we think about women having babies who are HIV positive that we look back into the 90s, where women were actually discouraged from having babies, to they were encouraged to have an elective cesarean section, to a time where now vaginal births are the norm and women are able to have absolutely healthy babes. And there's good movement and discussion now even around what breastfeeding in HIV positive women might look like in the future. So I don't know that we're there yet, but it's definitely being talked about in various circles, and I think that that's great for women. So this slide just basically shows that in 2018, in that calendar year, basically that fiscal year, that there were 42 HIV positive women who delivered. And over the years, when we look at how many women with HIV who've had babies, the number who've had successfully HIV negative children is quite incredible. And that speaks to a really concerted effort to focus on this group of folks. And one of the places that has been instrumental to support women at risk has been Sanctum out of Saskatoon. And the only negative I can say about this organization is that it's not here in Regina and it's not in Prince Albert. This is a much needed, very valued group of folks, dedicated folks in Saskatoon, who have been really instrumental in supporting women in their journey of having babies. And many of the women who have been through Sanctum, I think all of them, have all kept their babies with them. And it's been a really nice wraparound service for them in that community. I think access still is sometimes difficult for women outside of Saskatoon, especially outside of the larger centers, but nonetheless, it is there and it is valuable and it is being utilized. So kudos to Sanctum for that. I wanted to just sort of remind people, I mean, Saskatchewan is a very geographically diverse province. We basically have 3 major centers, and that's where the bulk of clinical HIV care is provided. Many people, of course, do not reside in these communities for whatever reason. They may choose not to. They've moved back to home communities, smaller communities. So this is where the main clinical care is provided out of. And I think keeping in mind the fact that people must travel for services is important to think about as well. I mean, even an hour to 2-hour journey out of Regina can be very challenging for some individuals given their resources, access to transportation. Are they able to get time off work? Do they have little children at home? We don't currently have bus service, so that definitely impacts people's ability to travel. So again, a variety of challenges regarding that clinical care and access to clinical care. So part of what we have talked about earlier, and which really Stu pioneered and that we facilitate as a larger team, is this mobile outreach clinical care. And so the picture on the right, you can sort of see some of the geographical areas that our larger team services. And this is a wide variety of service depending on community and community relationships and community-driven health priorities. So in some communities, it's specifically HIV or HIV and hepatitis C. In some communities, it's more of a chronic disease and primary care perspective. And within that chronic disease umbrella, certainly there is some HIV and hepatitis C care provided as well. We also facilitate where we can access to harm reduction and those sorts of things. So I think it's just nice to demonstrate to folks, you know, we take everything out with us. We pack the vehicle with everything and anything we can think of that's required with the intention of not impacting negatively that local health team or putting any additional pressure on them. And then making sure that folks know that we are available for home visits or to meet people where they're at if they're not feeling safe to come into that health system locally, because there still is, as I'm sure many people would believe or know, that there's still tremendous stigma, especially with respect to HIV in many, many communities. So part of what we've also done in terms of COVID, because of course we sometimes have not been able to go out to communities, we actually pre-COVID started experimenting with a virtual care app called On Call, which allowed us to have nurses or community health workers or local health teams go out to visit clients or have them in the health center and then link with physicians and nurse practitioners in the urban center to facilitate that access to care. And we've since now with COVID also included PEXIP in that. We use a tremendous amount of texting and phone calling with folks, which I think is probably a reasonable thing to know that we do that. I think it improves our capacity to see virtually with patients to support their medical needs, their clinical needs, their social needs. It enhances our specialist capacity because if we were traveling, you know, potentially 3 hours one way, 3 hours back, that's 6 hours that takes away from some clinical time. So by having a completely virtual clinic, we are able to see, for whatever that means, see a few more folks. Now that being said, of course, meeting people in person is by far the best way to go. It's just not always possible given our current situation, but I think that these are really amazing tools that will not go away once COVID is gone. I think they are really beneficial in terms of maintaining relationships, especially when access or transportation can be difficult for folks. Some of the things that we're working on in terms of moving forward as well is that we are working on some coordinated clinics with a few targeted partner communities, specifically around maternal child health and pre and postnatal clinics. We've heard that sometimes women have difficulty getting to care after they deliver. We certainly see women in some of the communities, HIV positive or not, who have some challenges accessing prenatal care. Some communities it's difficult to access lab service. Even in an urban center like Regina, to access lab services now with the COVID umbrella is very, very challenging for people, even people with all the ways and means to be able to do that. So these are programs that will be delivered in community with community. So we are taking our lead from the local health teams, and as we start to see women in those communities, we will adapt to their needs and their priorities. So it's really that community-driven model of care. You know, the future state may include access to ultrasounds in those smaller communities. So again, requiring that people don't have to travel. And of course, we'll still be able to provide referrals when folks need additional care and support. And then the other piece, which we are working on with Jolie and others on our team, is a Mama Pod. So this is a peer support model for and with women who are either pregnant or have been recently pregnant, in order that they can support one another. So it's really that peer model moving into different pieces of our health model in collaboration with the larger team and with the communities. So on that note, I'm going to turn things over to Jolie.
Okay, thank you. So just see here, I'll just see these slides. Okay. So we pretty much focus on the structural and social determinants of health. One of the things that I think people don't understand is when you talk about the determinants of health, that they are actually in different key areas. So a lot of times when I hear talks or I look at researchers, they talk about addressing the social determinants of health. But if you look at, if you could just put forward the tree slide, if you look at what these determinants of health really are, is they fall into separate categories. And these categories, I think that typically when you look at the addressing of the social determinants of health, people and programs and entities really look at those proximal determinants. So if you look at this tree, you'll see the structural are on the bottom, the intermediate are in the trunk, the stem of the tree, and the proximal are the leaves. And typically when we address determinants of health, we address the leaves. We look at early childhood, we look at poverty, we look at those sort of situations that we feel like we can control and have intervention with. And even at the intermediate level, we have intervention with, but we're really not going to have impact unless we look at the structural, the root determinants. If you think of any plant, if you don't treat the roots with nutrition and with light, you will not get a healthy leaf. And so if you can really think about the social determinants of health in that way, what has impacted the structural determinants is colonization, residential schools, and those impacts. And without going in and really addressing the key issues of poverty and food security and those basic necessities, we'll never really get to address the intermediate and proximal determinants of health. So at Wellness Wheel, we work deeply in community, side by side with community, developing community, capacity building community, because ultimately, their ability to lead their own way is what we're trying to get at. Their ability to have their own access to healthcare, their own doctors, their own nurses, their own services provided right in community, because that's really where these services need to be. You can go ahead to the next slide. Again, so some of the things that we think about that we all take for granted, especially in urban areas, is that we have clean drinking water, we have access to food, and we have all of these things around us. Even if you're First Nations or Métis, you still have some access in the city, although a lot of that is hindered by racism and structural barriers. One of the things that we did you can go ahead to the next slide, that we did when COVID hit here in the city is we did a pivot and we started looking at those interventions that we could do because we couldn't travel. And it was really interesting because we do a lot of food security work in one of our communities. We're very close with them. We partner with them a lot, and we weren't able to really travel and we weren't sure how to support them. And so one of the things that's been happening is we've been providing them with different resources such as canning equipment, pots and pans, food dehydrators, meat grinders, all kinds of things that you can think of to support their access to food security. One of the things that happens when people get ill and they don't have access to proper nutrition is that they don't get well. And we don't even have a good prevention system in place if we don't have our basic nutrition in place. So some of the things that we do, or that I do, is just go deep in community, side by side, and that they create the intervention that they want. And then we tie it in with traditional medicines. And the thing about traditional medicines, it's sort of taking off since COVID, everybody's dipping into traditional medicines. However, traditionally, we have a lot of protocols and teachings behind them. Our medicines are not something you can go pluck off a tree and hand to someone and say you can be cured. There's actually part of the living, breathing entity of why our medicines work is because they're holistic. The protocols around the picking and the understanding the medicines in general are life skills that'll teach you to be healthier and prepare you for living. And so one of the things that we look at, especially Suzanne mentioned the Mama Pod that we're developing to support these young Indigenous girls in their pregnancy, is to bring back those traditional birthing practices. Those practices in themselves are protective factors. For example, recently, I've learned that birthing from my community is considered a 40-day ceremony that has a beginning point and an end point. And to close the end point after the birth, for example, a mother, when she is in the birthing process, is out, and that baby's spirit is out and the mother's spirit is out, and they're navigating bringing that baby through. But it's a very vulnerable time. And so one of the ways to close the birthing ceremony after the baby comes forth is to give the mother traditional foods from her territory. So whether that be a bone broth or a berries or a tea. So that's one of the things that we're trying to do here in our communities, is to support the birthing moms with those bone broths and those teas and those tinctures so that they can have that ceremonial practice. And when you bring those ceremonial practices in, you have a natural affinity. One, you've got that DNA, that blood memory that's going on in our bodies. It's calling forth those ceremonies and those healing powers. And then we're seeing that just naturally kick in and support these women. So just by bringing in some of those rites of passage, those traditional ceremonies, those traditional medicines, and giving access is opening up a whole portal of healing that Western medicine just does not engage. And so we look at really harmonizing those two. What are the best evidence-based Western practices that we know work, because some do not with our people, and what are some of the traditional approaches that we can harmonize with and walk side by side in promoting that healing? You can go on to the next slide. In hindsight, I should have included some of the photographs of the actual work in the gardens and work in the communities that we're doing. It's invigorating to see. The Mama Pod in particular, we've taken this sort of peer model. So we have this HIV Hep C program in a lot of our communities, and we started, the communities told us that the most effective way to really intervene and to get support is through peers, HIV and Hep C positive peers. So we put them on the ground in different communities and in the urban centers. And what we've seen happening is that model works in chronic disease management across the board. So whether it's diabetes peers, mental health peers, addictions peers, that model is something that works, because often in community, if you don't have access to healthcare, but you have access to someone in your community who has the same illness as you and has walked through that journey, that person can be a support to engagement and care. I haven't disclosed this publicly since my husband passed away in 2019, but he passed away from untreated hepatitis C. And that was devastating, to be in this field and to lose my own husband to this disease. And before he passed, as he was passing, we talked about why this happened to him. And it was racism and shame in the system. And so I personally am dedicated to making sure that nobody in our family, in our community, in our homes, in our urban centers ever feels so much shame that they can't get help for an illness. That's a very Western way of thinking. We don't shame our people. We help all of our people. It doesn't matter if they're in poverty, if they're sick. It doesn't matter. Those are our people. Those are our brothers, our sisters, our children, our mothers, our fathers. I just buried my father to COVID a month ago. I just buried a brother 8 weeks before that. I buried my husband 2 years ago, and I buried my other brother 2 years before that. Indigenous men are dying left, right, and center in our communities. We're losing entire groups of people that have run ceremonies in our communities, and now COVID itself is taking away our elders. So we're in a very crucial point right now that we must use Western medicine to heal, but we must do it side by side with Indigenous ways, because we will not see the impact and we will not see it sustain if we cannot restore Indigenous ways of knowing and Indigenous health practices. We have our own medicines. We have our own ways of healing. We also need that Western medicine, and we need that access, but we need them to work side by side and not be challenged to get access to them. So access to either one is almost impossible in many communities. One, because of the disruption of the culture in the community, but also lack of transportation to urban centers where access is. So these are the things that Wellness Wheel really works toward. We also take a lot of students. We take medical students and counseling students and undergrads, and we also take community-based researchers, and we train them to support access. So we really want to increase the Indigenous health capacity provincially and nationally with scholars and students, both Indigenous and non-Indigenous people doing this work. So I think that's in a nutshell kind of my role. What I do is really support Wellness Wheel, keeping their eye on those Indigenous ways of knowing. I work very closely with the elders. I work very closely with the Federation of Sovereign Indigenous Nations, which is our governance for 74 communities. And I also work with the communities who are not FSIN affiliated, so that we always make sure that that voice is heard. So in essence, I think where we're headed now, because Wellness Wheel is constantly expanding and growing, is to really build up that mama pod, start bringing in those traditional rites of passage, traditional birthing practices. The thing about the mama pod, and Suzanne and I have been invited to, by one of the medias, to start doing probably a series, and I think we're talking about doing it on Indigenous women's health. To me, the crisis point is with Indigenous women, the young women of childbearing years. If we could start doing prevention in the childbearing years of Indigenous women, we could do a lot of prevention with HIV, Hep C, any of the illnesses children are born with, but also the endocarditis that Stuart was talking about. But also we're noticing rates and increases in other chronic diseases as well. And there's a lot of factors for that. Some of it has to do with sex trafficking and the selling of the body in order to get income to get drugs and alcohol. So I think there's so many factors that influence and affect our young girls and women that if we actually start to focus in on them, the prevention and recovery will expand to the families and expand to the communities. They say if you give a woman $5, the whole community will grow. So I think that's one thing that we have to think about moving forward, is really focusing on Indigenous girls and women and their health. I think that's everything.
I think there's a couple more slides, Jolie, but I'm not sure if they're advancing here.
I think this is what I was saying is this is the same thing. Like, we need to have these services within the communities. It's unrealistic and inequitable to expect that we have to come out of community to get services. I can't ask my 80-something-year-old mother who just lost her husband to get herself in a car to the city to get care by herself. So these services need to be accessible to our people.
There, I got the slide advanced. I think there's just a couple more slides. I don't know if you want to speak to any more of them, Jolie.
There's lots and lots of things that can guide us. One of my biggest pet peeves and frustrations is when I do talks and workshops, and I do it with non-Indigenous people, and everybody wants to offer anecdotal evidence. We don't need anecdotal evidence anymore. We have enough Indigenous knowledge, Indigenous scholarship, and Indigenous people on the ground and non-Indigenous allies doing work. We don't need anecdotal evidence. We know that we need structural change. We need systemic change. We need an honoring and an acknowledgement that systemic racism exists, both provincially and nationally. We need to honor that service delivery needs to change and that individual relationships are key. We need to understand and know what the TRC calls to action are. We need to understand the health calls and then how to engage those calls to action. So really honoring the truth in the truth and reconciliation process. I don't think it needs to be said that if we don't start now, it's only getting worse in COVID, and it's only going to continue to get worse. And however, I'm optimistic because I see the work that Wellness Wheel is doing is engaging care. And then what you see happening is the peers on the ground are sparking inspiration. And then there's just a natural uptake of their own interpretation of what healing looks like. And then that's what we want. And then they spark it and it grows forth from there. The only issue I see for us is we don't have capacity within Wellness Wheel to take on all communities, but hopefully over time we build that capacity in Indigenous health practitioners who would then be able to use these models that we're developing and supporting people with. I think that's everything. Oh, I can do this one. So we, one of the things we do is we come from a patient-engaged, patient-oriented approach. So we don't really use the term patient, but that's like the key academic term. We just call them community members, researchers. We start with the patients, the families, the communities. We start by asking them what they need, or usually we're already with them. So by this time, it's just grown into the next level of what strategy they want to uptake. And we just follow their lead. And usually what I do and with some of our team is we find grants and we write grants and we get the money to them and they do their intervention and we just grow together. And then we evaluate that intervention and we do it side by side with the elders and with ceremony. We take everything I personally take everything into ceremony before we submit a grant, before we do anything. So even if we don't get it, we just know that it wasn't meant to be. If we've done it through ceremony and it doesn't work out, then it has worked out the way it should be. We're very spiritually engaged and spiritually led, which you might not know because that doesn't really come out in the literature that we write about, because academia doesn't care about spirituality. But that is the foundation for which we operate, because the late Noel Starblanket described it to me and mentored me in this. It is in the obtaining the balance between the mental, the emotional, and the physical, that the spiritual will get restored. So it's working on the mental, the emotional, and the physical that we can get to spiritual well-being. And that's where we have, when our spiritual soul and our spiritual well-being is disrupted, which it was in colonization and it was in residential school, and it is, if you just look to the south, what's going on, how can our spirit not be disrupted? This is how we restore it. It's through indigenous ways of knowing, rites of passage, traditional medicines, language, and culture. That's how we're going to get there, supporting that restoration. I think that's everything now. I've said this, yeah.
So Savannah, I think that's the last of our slides. If anyone has not checked us out on the Intergoogles, you can check our website out, www.wellnesswill.ca. There's lots of good information on there. We're happy to take any questions.
Thank you so much for sharing your knowledge with us today. That was wonderful information for everyone. Just want to remind everyone that if they do have any questions, to enter them into the Q&A box in their Zoom bar. I will start things off. So in terms of prevention strategies for HIV, how accessible is a prevention strategy like PrEP for people who may live in rural and remote areas or live transiently? Is that something that's not going to be accessible or ideal?
I can try and answer that. So PrEP, which is pre-exposure prophylaxis to reduce the risk of acquiring HIV. There's a few pieces that we need to kind of think, or we need to look at. So it's a pill a day. We can certainly improve ways to access that. So for example, we've done a lot of work with PrEP in kind of, our word would be task shifting, meaning that it doesn't need to be a physician that needs to prescribe it. Nurses or nurse practitioners could be able to prescribe it. Pharmacies can do it with a partnership with a physician and to make it more accessible. And it's a challenge to change the mentality amongst physicians that, hey, you know what, why can't, sign an agreement with a pharmacy who can prescribe it, because that's the only place someone engages in care. There's also a bigger mentality with that in rural areas, especially amongst people who use injection drugs. And there's bias in what we do in our system to think that someone who's injecting doesn't actually care about HIV or getting HIV, when they do. They really do. I mean, it's the addiction that kind of overrides things, and they really do benefit from that. Yet we don't offer the same services. PrEP would be one example. I can give you a whole ton of other ones that we do to people who don't inject drugs, because we have inherently a bias, and that's available. So this does need to be rolled out. You look at our HIV rates. We need to look at better ways and other ways of doing things, because for the past 10 years, whatever we have been doing has not been working. The rates haven't changed. They're the same. And so we need to do things differently, look at different ways. Why can't peers help prescribe PrEP? Like, why can't I have a relationship with a peer, say, who's well connected in the community? They could or may not be HIV positive, but they get a phone and they get an app like the PECSEP for telehealth. and accessing treatment in a different way. Now that's, I mean, perhaps very Western based, but you know, the peer model is the way to go. They know the answers, and they should be part of the care provider team. So I think we need to look at doing things in a different way. I think that model is going to be, if we want to access the highest risk, is the best way to go. Pharmacy is another, and we've got to task shift this down, meaning as a physician, we got to stop trying to control things. So that the answer is it should be more available, and we need to look at methods to make it actually accessible to the people who need it.
I'd just like to follow up with that a little bit on the peer program. One of our team members, Mamata, Pandy, and I have been working on, we train our peers on the ground. We actually don't call them peers, we call them health advocates. And our plan is, Mamata's been studying right now, I'm gonna mess up the name, but I think it's called the Community Health Worker Program, which is a national model out of the UN. We would like to see a model like that come to Saskatchewan and Canada, where we actually train and give credentials on the ground to these people so that they could do something like a PrEP or something a little higher level medically at some point. We don't want it to be a barrier to be a peer, but certainly if a peer wants to engage further and get more credentials and get more skills, then that would be a win for them.
Well, and actually, if I can jump in just in terms of prevention and adding to the PrEP talk. So we've had a partnership with a pharmacy in Regina where we supported them to do HIV point of care testing. And that was novel in that pharmacists previously were not permitted, and legislatively still are not really permitted to do HIV point of care testing. But what we demonstrated was that it was a really great place for people to access testing, and they had clients cold call them from other cities actually who did not feel safe to have testing in their smaller urban center and wanted to come to Regina. Those folks were likely lower risk, but it was a really nice way to engage patients, and it really was a good use of pharmacists' time in that they talk to people all day long. They're great at engaging, they're great at counseling, and this particular pharmacy really did well with this. And since then, we've now partnered with them around PrEP. And so they are offering PrEP to people who inject substances here in Regina. And the uptake from the individuals who come to their place of business has been really phenomenal. And I wonder, you know, now with HIV self-testing being approved in Canada, and so trying to get access to those tests, I wonder what the thoughts are with respect to rural and remote communities. Because the manufacturer has assigned a fairly significant cost of $30 for each kit. I might be able to order it with my credit card and have it delivered to my house, but you know, how do people in smaller settings do that? And that doesn't even begin to address, what if it's a reactive test? Then what? How do you get a confirmatory blood draw when there's no phlebotomy anywhere near you? How do you access an HIV provider, whether it's Dr. Skinner, whether it's a nurse practitioner or a registered nurse, a family doc, no matter who it is, how do they access care and treatment going forward? So, I mean, I think these are all nice tools, but I think it demonstrates that each community, whether we're talking about the Heritage Core area in Regina, where they're talking about a First Nations community, whether we're talking about a northern isolated community, each intervention has to be tailored to that community. And I think, you know, Stu and Jolie are bang on in that peers are willing and able to do a lot of this work in collaboration with healthcare providers and communities. And, you know, the question is, why are we not using them? You know, we need to think about who's not accessing our care, our services, wherever they are located, and why aren't they, and how do we reach those folks? It's not about who's accessing, it's about who's not.
Absolutely. So another question, how can healthcare providers or people work with or among health systems promote harm reduction, particularly during COVID-19, where access to services are even more strained? It's harder to get testing, it's harder to get, you know, supplies or access to things. How can people within this system promote harm reduction?
I can try to take a stab at that. I don't know, Stu, if you want to.
You go first.
Okay. I think it's a really great question. I think that we are seeing that even in the larger cities, we're struggling to provide harm reduction. I think we have to advocate for people who we work with in terms of what do they want to see? Where does it work for them? How do we leverage the larger organizations, institutions to say, look, COVID is absolutely a need. We have to all hands on deck, everybody has to pay attention to that. But what we're seeing is even more substance use, more social isolation, more physical isolation. People are using much more than they normally would. We're seeing that with the overdose crisis. And this is not going to go away. People who acquire HIV today, once COVID is gone, are still going to be HIV positive. So, we have to sort of think about how we're allocating our resources. And there has to be room at some point to maybe task shift or look at different opportunities. Maybe it's using the pharmacy as a harm reduction site. Maybe it's using secondary distribution in those communities. Maybe going to the peer network and say, how can we work with you to get these supplies out? There has to be a way to get those out. And I think from my experience, a lot of providers are just scared to even have the conversation, scared to sort of say to the person they're working with, what do you need? How do we make this better for you? How do we provide services for you in a way that works for you, right? Most of the services that exist are for the benefit of me and for the system. They're not, if we were truly providing services that were for clients, we would not be offering 8 to 4:30 services, right? Monday to Friday. That's the fact. And the same would be true for harm reduction. So I don't have a really good answer. Know who you can tap on the shoulder in your own community, know who you can sort of ask for support from, know how you can kind of navigate some of those landmines in terms of the systems. And know what the currency is in terms of who you're talking to. Is it a financial piece that you have to argue? Is it a human justice piece? Is it, what is the argument? And that sometimes helps in terms of getting some traction. So I don't know if Stu or Jolie has any comments. It's a hard one though.
Yeah, it's a great question, and it's a frustrating question. At the beginning, kind of when I talked, I said COVID highlights is bringing out where the gaps are, and this is a comment that's exactly that. Full disclosure, I'm actually the pandemic lead in Regina, and the challenges are massive on a system level, and the system now is kind of failed. I won't say failed, but can't provide those needs for those people who need those services, and we need to find other ways to be able to apply it. Because if it can't be provided, then it shouldn't be restricted from other people providing what's needed. And that's kind of where we're at. So if we can't do this, which we can't, or unable to, then you can't restrict others from providing that. And it should be say, look, now we've got to do things a different way. That's going to be able to provide that support. And it is a challenge on this, like the system struggles. I say the system because I don't think it's any one individual. It is this massive system that cannot adapt, change, is stuck in regulation, and wants something that's zero risk and is afraid to do anything. But we have to look at different ways to be able for the people who need it to be able to access it. I don't know the answer to it. If anyone has any thoughts, love to hear it, or Jolie, but you've got to change that. And that same goes too for mental health. We've seen the mental health services now, they're absolutely not accessible. And the only way we're going to do that is through community, right? And your community could be your street. Your community could be a neighborhood in an urban center community, could be a First Nation community, could be a group of friends. But community is really what you need for these things. And there's just this massive gap in services, and that's just being completely highlighted by this COVID pandemic.
Thank you both for those thoughts. It's really a very complicated problem. We have reached 3 p.m. now, so maybe we'll just ask one short question so that we don't hold you up too long. Kristen is wondering if LaRange is on the radar for a community, as a community for engagement with Wellness Wheel.
No. We have, like, I know there's a lot of communities that ask to be a part of, but you have to understand that we're a small group, and it was started with Stuart and his relationships with one community that sort of expanded. And now we have about, I don't know, I hear different numbers. Today I heard 10 and 20, but sometimes I hear 19 and 26. And we're a small group. So we're trying to expand capacity within ourselves and more health scholars and indigenous knowledge keepers and things like that. But we within the communities we're in are already growing in those communities, right? So for us to go to a new community and engage would be, it would really hurt everybody because we don't have the resources. However, there is an entity that can help, and that's the Network Environment for Indigenous Health Research. That's the name, the NEAR. We were actually very lucky in Saskatchewan to get a NEAR, which is a CIHR grant. It was $5 million over 5 years, and it's to support capacity building of First Nations communities and eventually holding Tri-Council funding. So what I would recommend to LaRange, and I actually know LaRange is already engaging with several academics. It's already movement up there. It's not Wellness Wheel, but there's movement in LaRange with other entities. So I would just support any community and kind of reaching out to the NEAR if they want some support in research and medical intervention. I think there's some support there. And there's small grants too. We just, because I'm the co-scientific director of the First Nation side of the NEAR, there's a Métis side, and we just had a call for grants and for communities. So several First Nations communities got, $5,000 to $10,000 grants to run little health interventions. So I would highly recommend you Google the Saskatchewan NEAR and you look for the next call if you're a community, and maybe a First Nations or Métis scholar that you want to connect with to support you on your journey. And the NEAR can help build those relationships. So that is a great place for them to get a hold of and sort of say, hey, we're a community and we have a water purity problem or a health problem, and we want a scholar, and then they can do a match and support the community with a scholar, and then helping them to kind of do what we do. But what we do is unique, and I always have to say this because I don't want to set anyone up to think that they can do what we do, and here's why. What we do is out of love, and that is a cheesy thing to say, and you're not going to see it in an article, and it's not going to be something we tout because we're academics. But the work behind the scenes, many of us are unpaid. We don't work 8 to 5. We hardly take vacations. Not the average person on the planet wants to do that. But we as a team are unique. Look at my passion. My husband died of Hep C. Of course I'm going to fight for this. Of course I am. The average person may not. So you can't necessarily go and replicate Wellness Wheel. You can certainly use our frameworks. You can use our models. We share everything we do. We give it away. But the ability to really do it has to come from the heart, and not everyone has that. So you really have to know where your passions lie and what you're capable of doing. And I wouldn't necessarily say go out and replicate what we're doing, but derive it from your partnership and your relationship that you have and create it from there. Then you can replicate it.
Yeah, and then just one quick comment is to Kristen. I mean, we can always, if you want to reach out, we can talk, share ideas. Happy to educate. I know some of the physicians up in LaRange that to give talks or any kind of support education to just provide some ideas as well, or even just discuss. Certainly we're available for that, and anybody else.
And even in terms of peer expansion, Kristen, I saw you put a note about the peers. So we don't have all the answers, but we're definitely happy to share and talk.
Wonderful. Did anyone have any last thoughts that they would like to share before we close up for the day? Well, thank you so much for sharing your knowledge. It was really wonderful to learn all of these different aspects of rural HIV prevention and care. I want to remind everyone that this presentation was recorded and it will be available for later viewing. I'll share the link to the recording in a follow-up email along with information about future webinars, including February 4th's webinar on trans and non-binary sexual health and pregnancy with Dr. Megan Clark. The Saskatchewan Prevention Institute has also created a number of resources, evidence-based resources over the years specific to HIV, including the recently updated HIV and Pregnancy Guide to Care. You can find this resource and more by visiting our website. Direct links will be provided in the follow-up email for this webinar. When you close this browser, finally, you will also be directed to an evaluation link. Completing these evaluations helps us determine the focus and format of our programming and allow us to better support everyone as professionals in this field. So once again, a very warm thank you to our speakers today, Dr. Jolisa Sakamoose, Dr. Stuart Skinner, and Suzanne Nicolay for sharing their knowledge with us and sharing this wonderful presentation. Thank you so much for your time.
Thank you. I just want to say Megan Clark's a Wellness Wheel doc, so you'll have a Wellness Wheel doc. Thank you, everyone.
Thank you.